And hypoglycemia causes, like I said, it's a repeat, causes the release of epinephrine, which causes temporary decrease in milk production. And there are a lot of other factors why how the milk production can be interfered. I'm going to talk about that as we go along. So now, coming to the oral medications, use of oral medications during lactation. The American Academy of Pediatrics, they consider tolbutamine, a first-generation sulfonylurea, to be safe during lactation. Although even small amounts of tolbutamine crosses breast milk, there has been no adverse effects reported in literature. So it's considered to be safe during lactation. And I know a lot of the providers have concern about this, but this is a documentation that you can provide to them saying, hey, it is safe, this is what it is, so it kind of puts them at peace. So some of the studies showed that very small amounts of glipizide and glyburide passed into breast milk compared to metformin, and both were found compatible with breastfeeding. And also we see that no matter if it's tolbutamine or metformin or glipizide or glyburide, most of them do pass breast milk, but it's very clinically insignificant, and it's not really metabolically active to have any adverse effects long term. Although metformin is considered very safe during breastfeeding, there was only one long-term study on infants about for 3 to 6 months, which suggested no significant difference in height or weight or motor social development. So what helps is I have a lot of patients personally on metformin because I deal with a lot of PCOS patients. They do get a lot of preconception counseling. I know it depends on different setting, but which is a good thing to get a lot of people for preconception counseling. So metformin, from what I've seen, when I get a patient with PCOS or pre-existing diabetes, so already on metformin, in my opinion, I would recommend, a recommendation would be to just leave them on metformin throughout the pregnancy and through lactation because it helps from preconception by lowering the glucose, and helps with ovulation, helps with implantation, and it's believed to help with lactogenesis. So it helps being more sensitive. It helps you being more insulin sensitive. And at some point, if I have to start the women during pregnancy on insulin, I would still leave the metformin along with the insulin because it keeps them a little more sensitive. So it is perfectly okay to leave metformin if you had a patient with PCOS or pre-existing diabetes throughout the pregnancy into lactation. Although there are a lot of providers who feel it's okay, just to pull them off after first trimester, it's okay too. But that's what the study kind of shows. It's kind of safe to use during, definitely use during breastfeeding. So I've added other medication table. There are a lot of, although I'm not going to go into details, but there are a lot of other medications you get pre-existing diabetes into pregnancy. There are a lot of medications which is recommended or not recommended, like the ACE inhibitors, the ARBs, the beta blockers, calcium channel blockers, methyl-dopa, statins. So the ones which are approved by AAP are the calcium channel blockers, and methyl-dopa is approved by AAP. The ones which are not studied are the ARBs. ACE inhibitors not recommended in the first 2 weeks of life. Statins not recommended during lactation. But like again, I said, if you got a patient who's a complex patient with severe dyslipidemia or other issues, I would just go with what the primary care or the OBGYN kind of decide as a team as to what would be appropriate for the patient, because sometimes that probably would benefit more during the pregnancy. Now, depression. So depression, we come across depression many times, although many times in many cultures it doesn't come out from the patients, and you do recognize the symptoms, but the patients are not really verbally talking it out. So it's a lot more. It's cultural, like I said, and the depression can actually would have create a lot of difficulties with breastfeeding, and if a mom is having constant problems with breastfeeding, it could be a flag for postnatal depression. It might not be. It could be just a breastfeeding issue that needs to be resolved, meeting with the lactation consultant. But that could be a red flag for postnatal depression. And depressed women, it's research saying, the research shows that depressed women tend to breastfeed less or for shorter duration or even opt out of breastfeeding. So utilization of antidepressant with lactation does help with the relationship between the mom and the baby, and it does help the mom manage the sugars much better if she were to be depressed and without any medications during breastfeeding. So how is it going with the breastfeeding and psychiatric medication? So there's no formal guidelines regarding use of psychiatric meds during SSRIs, including SSRIs during pregnancy and lactation. I would say the best practice is to always use an individualized risk-benefit analysis of the severity of mother's depression, and then make a decision on oral medications. Because it's a tricky situation at that point. Do you want to start them or not? And also want to make sure you identify depression, the signs, and make appropriate referrals, which would help mom with breastfeeding. So all meds, all the psychiatric meds, if the moms were to be on psychiatric meds, all the meds are secreted into breast milk. And there's research on that, and incidence of adverse effects on nursing infants appears to be relatively very low, and research shows long-term neurodevelopmental effects of infants not predictable, but definitely maternal-child relational difficulties in untreated depression are very, very well documented. Fluoxetine, the most studied SSRI in pregnancy, I just put that in because that's the most studied SSRI in pregnancy, and has long half-life, and it's usually not recommended in breastfeeding. Toxicity reported with mood stabilizers, the one that I put in parentheses, there is reported toxicity, so you have to consult with the physician before it's started or make an informed decision. So the information on use of antipsychotic drugs is very limited. So at this point, like I said, again, we will have to go back to the best practice analysis to figure out what is actually needed for a patient. So the nutrients talking a little bit about medical nutrition therapy. What are the nutrients? So the nutrients for lactation. You're looking at the dietary protein and carb has no major effect on breast milk. Meaning, I know there are a lot of questions it's asking. I do get a lot of questions from patients asking, what should I be eating? Does this help my milk production, or is it going to make my milk go bad? Is it bad for the baby? So research has shown that dietary protein and carb has really no major effect on breast milk. And the fat-free, about the fat, there is some effect by diet related to type of fat and maternal body composition. So meaning there is increased saturated fatty acids, unsaturated fatty acid, and diet can increase fat concentration in breast milk. And so the diet does not really seem to alter our concentration, big deal of cholesterol and phospholipids in human milk. But it also depends on the pre-existing diabetes, what was the cholesterol issues, and what is how is the diet, is it all saturated fat? So it depends on that. So the diet consisting of less than 1,500 calories per day has been shown to decrease the breast milk volume in lactating women. And if weight loss is desired, which pretty much everybody desires weight loss, it's recommended that women aim for no more than 4.5 pounds of weight loss per month. without compromising the milk production. So there are a few things that I talk to women, kind of summarize, give some bullet points and the usual question that I get is, okay, what is going to decrease what is going to affect my breast milk production? So I do tell them there are some things you need to look for. You want to definitely make sure you eat more than what you were eating during pregnancy. So typically you say about 250 to 300 extra calories, but you don't really, I don't really go by but it depends on, I just tell them you need to be eating a little more than that. So if you were to keep it at 1,800 calories during lactation, that is considered to be safe enough to support breastfeeding, to produce breast milk, at the same time not compromising on the volume of breast milk. So there are a few things. What I talk about is you want to make sure that you are not, if there's a decreased caloric intake, it does reduce the production of milk. If you don't get enough sleep, so I say when the baby sleeps, you got to sleep. Which is not always happening. So I know, of course, once the baby comes out, it's going to be so chaotic at home. But I say it's not just the mom, but everybody needs to take turn to sleep because everybody is helping each other. So the decreased caloric intake, decreased sleep, rapid weight loss, we don't aim for more than, I would say, 0.5 pound to 1 pound per week, what would be ideal. No more than 4.5 pounds of weight per month. If not more than that, you start seeing a decrease in breast milk production. And also a long gap for breastfeeding. So sometimes the moms are not decided, they're undecided. They say, you know what, they go in with saying, I'm not going to breastfeed. But they give it like a couple of weeks and say, oh, you know what, I really want to breastfeed now because I know the benefits. But it's all about, that's when they see that the breast milk production is tapered. It's all about stimulation of the breast. So that's when we want to talk about all this before they actually deliver. So they are well educated on breastfeeding rather than just going and say, oh, you know what, I'm not having enough milk. I should have done this before. So, so those are some of the things that I talk about. And just to give you an average, the average milk production is about 0.78 liters per day. So I'm going to repeat that. The average milk production is about 0.78 liters per day. This is just an average. And that is from birth to 6 months is 0.78 liters per day. And from 7 to 12 months, it's about 0.6 liters per day. So an average weight loss during the first 6 months postpartum is about 0.8 kilograms per month. That's 0.8 kilograms per month. And the energy output on an average is about, through breast milk, is about 500 calories per day. And in the first 6 months, then it's on an average about 400 calories for the second month. So this is a really positive thing to say to create encouragement for the moms, because if they say, if you say, oh, you know how many calories you lose when you breastfeed, that is a big motivator for the moms to actually start breastfeeding. So, so those are some of the facts.